well, I'm talking on quite a controversial topic of transforaminal endoscopic decompression of stenosis. Now, in regular stenosis, where patients are fit to undergo a surgery in a routine way, then naturally we choose an interlaminar route. But there are situations with the growing and the aging population that we are most of the times forced to undertake a surgery under local anesthesia. So in majority of even younger patients who have unilateral lateral recess stenosis or unilateral stenosis, unilateral symptoms, we can choose transforaminal decompression of stenosis provided one is comfortable in performing it. Now let's look into the anatomy. This is a reconstructed video of walking through the spinal canal. So if you see the part of the spinal canal more laterally, that is the narrowest part of the spinal canal. So we have to answer one question: is there real central stenosis? Or is it all lateral stenosis and bilateral symptomatology is bilateral lateral stenosis? Now these are the questions to be answered. I myself do not know about it. So, but if you look into the morphology, it is the lateral aspect of the spinal canal which is the narrowest part. Now if you look into the pathogenesis of how the disc degeneration and progression into stenosis starts from by the classical diagram of Kirkcaldy-Willis, you see a primary disc-related disorder where you have annular fissures and when you have internal disc disruptions and disc herniations, which over a period of time leads to secondary disc-related disorders, which is primarily posterior. So primary disc-related disorder is related to the disc, whereas the secondary disc-related disorder is related to the facet joint. So stenosis is primarily pathology of the facet joint. So the way we are imaging studies is not in the plane of the disc, but if you have to image stenosis, probably we have to image it in the plane of the facet joint, which is going to be the oblique coronal imaging, to see the entire pathophysiology or pathoanatomy of stenosis. Ultimately, all of them lead to lateral stenosis and then over a period of time progresses to a multi-level stenosis. Now the primary culprit, the disc. As you see the natural history of disc degeneration, finally what you end up with is a disc resorption with formation of osteophytes and collapse. Now you're going to have this annulus, which is collagen, which is going to bulge and which is going to raise the floor of the spinal canal, compounding to stenosis. The second one is facet joint. You can have a superior and inferior subluxation of the facet because of disc. You can have anterior and posterior, and you can have facetal rotations. Now these facetal rotations, if part of the facet comes within the spinal canal, it is going to cause a lateral canal stenosis or lateral recess stenosis, because the nerve is going to be pushed inside the lateral canal and the facet is going to override that. But if it goes outside, it is going to be the extraforaminal component or the foraminal component of the exiting route which gets involved in the entire pathogenesis. Now ligamentum flavum is not just an innocent bystander, but it is an accomplice in the entire pathology of stenosis. So normally ligamentum flavum is classified type A, B and C, whereas B and C are more extending into the spinal, in the foramen and in the extraforaminal region, these are the patients who are more prone for stenosis over a period of time. So if you see into how much of ligamentum flavum is there, ligamentum flavum is about 12 millimeters within the spinal canal, and the similar amount is in the foramen and maybe the similar amount in the extraforaminal region as intertransverse ligament. Now if you look into the various papers of pathoanatomy, this is a famous Japanese paper in Eurospine published in 2005. The imprint of the ligamentum flavum in stenosis is around the axilla of the exiting route. So it's going to be the roof of the axilla and the shoulder of the traversing route, or the axilla of the exiting route. This is the primary area which shows as anatomical stenotic element. So as you see, what happens with the ligamentum flavum? So it is just an accomplice. As the disc resorbs, there is a collapse, there is a mucoid degeneration in the ligamentum flavum, and there is a concentric compression of the thecal sac, which naturally pushes the traversing route into the spinal canal, causing lateral recess stenosis. So the neuroclaudication, I'm not getting into it, but the symptomatology even in stenosis varies depend upon where the compression is. Whether the compression is at the level where the CSF is, the symptomatology is completely different as compared to the symptomatology directly on the neurological structure, that is the root. Central symptoms are primarily because of the Wallerian degeneration that is occurring and the sympathetic feedback that is coming in. So you see all the stenosis coming around this area of the superior articular process, the lamina part of the SAP, and this is the pathology primarily in majority of patients. I don't say that this is in everybody, but in majority of patients. So what do we need to deal with? We need to deal with the superior articular process, which is primarily the horizontal component. Now the vertical part of the superior articular process is a natural, what you can say, regressor of degeneration. As you degenerate, the disc collapses, the superior articular process vertical component is going to abut against the cranial pedicle and the degeneration is going to stop. There is not going to be further collapse in the foramen. But in a surgery, if you remove this part of the superior articular process, the natural history or progression of collapse will continue and you will end up in a pinpoint foramen. So the horizontal component of the SAP is the one which is responsible for majority of symptoms, as we have seen from anatomical studies. The foraminal ligaments, because of chronic inflammatory conditions, become fibrotic and can act as a guillotine over the exiting root. The ligamentum flavum, as I said, it is an accomplice, directly doesn't get involved, but with the pathology that is happening all around, it gets involved. Disc herniations, pars defects, osteophytes and facets are also responsible for various kinds of things. So the transforaminal, as I told, this is the area where the transforaminal endoscope is going to lie, and this is the area of the pathology. We've been talking about it all through. So superior articular process, how you do? Directly get into the foramen, identify the superior articular process in the upper part of the foramen, protect the exiting root with your tang of your sleeve, just take off the ventral part of the SAP, and as you take off the ventral part of SAP, how much do you need to take off? A couple of millimeters is all that is required, because the vertical component of the SAP is going upwards and sooner or later is going to abut against the cranial pedicle and the pathology is going to stop, or natural history of progression of collapse is going to stop. So it is this much to entirely decompress that area. Ligamentum flavum, as you see transforaminally, you are able to see the part of the ligamentum flavum over the roof of the axilla. So you have the exiting root, you have the traversing root, and there is the part of this ligamentum flavum which is crowded. Now this part of the ligamentum flavum needs to go. You can see vascular tissue because of chronic compression here. This is the exiting root, this is the roof of the axilla, and this is the traversing root. Now this is the part of the ligamentum flavum. This needs to go completely, and you should be able to get inside over the nerve root in the upper part of the foramen. Some cases where you have pars defects, you may have some kind of redolent tissue there, a non-union something tissue which needs to be taken off. Laser and Carrison punches are excellent tools to take off. Now, how much do you go till you completely decompress the entire area? So, how do you see intraoperatively? Within one single view of your endoscope, if you are able to see the exiting root, you are able to see the axilla, and you are able to see the traversing root with nice transmitted pulsations of the dorsal root ganglia, this is sufficient amount of evidence to say that you have decompressed it well. Because you are not going to see any fat because of the chronic compressions, you may see some fat, but not always. So that is what is going to happen. Now, here I propose something different. You want to do the foramen, you want to do the inlet zone of the lateral stenosis, and you want to do the mid zone of the canal. So we talk about a new concept called as forecesoplasty, wherein it's an oblique trajectory using the Maxmore system, as Sanjay rightly said, that you can do a lot of outside out. This is a kind of outside out. So you go directly. So what is the extent of decompression normally that is required with the stenosis? A little above the tip of SAP to half of the caudal pedicle is the area of decompression, and that is exactly what you want to do. The special kinds of drills, which are complete drills, and some 30% cutting drills which are used in this process. The medial part of the thecal sac or the root, traversing root, is well protected by the ligamentum flavum, which is quite thick here. So you have a natural barrier to take care of that. So you go in. So I will just try to take it ahead. So you first put in your Tomshidi, and then directly go ahead with your drilling system starting from 4, 5, 6, 7, 8. Now 8 millimeters is a lot of space. Okay, the size that you are looking in an MRI is about 4 millimeters. I'll just speed this video up so that you'll be able to see. So what do you see finally? Obliquely half of the SAP is gone. You see half of the caudal pedicle, a little bit of the superior medial part of the pedicle is gone. You see so much of space that you are able to put a 3 the probe inside to completely see and confirm. So what do we do in forehead cystoplasty? This is the kind of decompression. So this is one of the few kinds of decompression where you can increase the interpedicular distance mildly. Most of the surgeries target in increasing anterior posterior, but this can also do it in the other way because you are directly getting into the lateral recess, which is the middle zone of the lateral recess. So you see a couple of MRIs, CT scans that we have done. On the top you can see that that's the lateral recess preoperatively and the mid zone after the surgery. The second one, the overhanging part of the SAP, you can see the overhanging part of the SAP is gone completely. And the third is the coronal section. You can see the medial bump of the pedicle. The medial bump of the pedicle is completely gone. And last is the sagittal section where you can see the migrated superior articular process, and here you can see the attenuated SAP. So what do you need to do? How much of evidence is this for this? Am I really violating the facet? So there are so many papers. I have just represented one long-term result. There is no great, what you can say, instability occurring in these cases because majority of the facet joint is at the level of the pedicle. The part at the level of the disc is hardly anything, little. And 45.5% was the increase in the volume when you do a bilateral decompression transforaminally as compared to 34.2 when you do it interlaminar. So this gives a sufficient amount of courage to do it. What we need to do, just rethink about the whole pathology. It's just not removing tissue and from how and where you're removing the tissue. Thanks a lot for your patient listening. Thanks a lot for the study.
Thank you, sir.